actually, but I've definitely put mine to Simon. By the way, quick thank you to our sponsors today, Gilead, Roche and Janssen. Thanks indeed to both. Okay, just to start things off, I know Kira and Jan and the gang at CLL Ireland, we're very conscious. A lot of the vocabulary and the language used when discussing CLL can be a little technical, a little daunting. So to start off, they thought it might be a good idea to take you through some of the vocabulary, demystify things a little bit. Two of our speakers, who I'm going to introduce in some detail later on, are going to jump up and join us here, Nick York and Brian Hoffman. If you guys could make your way up to the stage, and I'm going to give you a microphone each. Thank you guys.
I think I'm good here, and I think...
But the other person I'm going to ask to start things off is Michael Rynne. Michael has two roles. He is Communications Officer for CLL Advocates Network, an international organisation that helps countries set up their own advocate groups. He also works, and I know this from experience, he works tirelessly for CLL Ireland in his spare time. I'm not sure how much spare time you actually have. But ladies and gentlemen, please give a warm welcome to Nick, to Brian and to Michael Rynne.
You have this. Can you hear me? Oh, yeah. Okay.
There's a clicker on the desk.
Hi, everybody. Can you hear me?
Yeah.
Well, firstly, I'd like to say thank you all for coming the distance you have and attending. I've attended and I helped with a lot of other groups to organise patient meetings, and it's very rare that we see so many come together in one room. I'd like to thank CLL Ireland for the invitation to come and join. With Brian, we've been working together quite some time, and also again thank the sponsors for supporting this event. Can you hear me?
No, that's better.
If you stick right up to
Right
up to yeah.
I've never liked handheld mics. Let's try and be a bit participative. Before we start, the plan is we're going to do a quick 20-minute run-through of the basics. Yeah? Now, I'm a patient, Brian's a patient, and Michael is a carer. Michael's very patient. So we're going to be pretty basic. We're talking to patients as patients, and a lot of the terminology, as we explained, it really is like Chinese, if you're not familiar with it. So first of all, it'd be a great idea to get an idea of how much experience people have got in the audience. So I was going to ask a question, are there many here who have been diagnosed or are with somebody or supporting somebody that's been diagnosed in the last year? Okay, quite a few of you, yeah? How many people have been treated? Wow. How many people are on watch and wait? Okay. And obviously we'll explain watch and wait if people aren't familiar with it. How many people consider they know a lot about CLL or their own disease? Okay. I don't need to ask the other question then, do I? And the other question is, how many people find they're able to get as much information as they need? Not many hands. Okay. Well, thank you very much. That at least, the idea of this event is to make sure we all work together, to be participative. Don't be frightened of questions during the Q&As. There's no such thing as a silly question. I remember coming to my own first meeting inside the diagnosis of a year, and it really was Chinese. But it does get better with time, so we'll help. So if I try and use the clicker to explain, so I'm going to kick things off. Michael's then going to dive in and talk a little bit, and then Brian. Brian is a little bit unique, as well as being Brian, and the patient. He's actually also a doctor, yeah? So he can bail us out if we get it wrong. Yeah? Okay, chronic lymphocytic leukemia. I think many patients, when they hear that straight away, they hear two names. Yeah? Leukemia, oh my God, wheels are falling off the bus. Am I going to die? The other one is chronic. Now I know on the UK side, we tend to use chronic the wrong way. People think chronic means really serious or I'm a malingerer. It's used in so many different ways. So I think what we need to do is just be clear about the terminology here. Chronic, is about a slow clinical course. Chronic means slow growth. Chronic means it's a disease that if it's going to progress, will slide back a little bit so it's not cut off as opposed to fixing it. What we don't need to get confused with, if we do the game, is acute. Acute leukemias is what you tend to immediately associate if you're recently diagnosed with leukemia. There is a need for speed. There is a need for urgency. With chronic lymphocytic leukemia, it's the opposite. And that's what we will have to learn to deal with together. How do you cope with moving forward with a slowly developing disease that may or may not develop? How do we deal with that? So quickly moving on, lymphocytic, that part of the name just explains that it's of the lymphocytes. The lymphocytes are one of the white blood cells that help police your body. And basically, this talk will explain a little bit later on in more basics what the impact of CLL does on them. And leukemia. Leukemia is a really old-fashioned name. It came out of scientists looking at test tubes which were predominantly white. And leukemia just means of the blood. It just came from an old name of white blood. And in CLL, we'll explain some of that later, it presents in the blood, so it's been given the leukemia tag. And that's the biggest problem I think a lot of us face when we're first diagnosed, hearing that word. So hopefully today, through the day, we can make a little bit more sense of all of this. Now, I don't know, are there many people in here who have been diagnosed with SLL? Small lymphocytic lymphoma, is it?
That's correct, yeah.
Okay, so there's a few here. So to explain to others that don't know, there are basically two types of CLL. Essentially, they're the same disease, or the same disorder, if you prefer that name. And one presents more often quickly in the blood, in a more liquid form, and mobile form, whereas the other will present and be more nodal, making you more lumpy, so CLL tends to be more of the blood and more mobile, and SLL tends to be more fixed and presents as lumps and bumps in your nodes and in other organs. And essentially the same because it will eventually spill to the blood, and they're both treated exactly the same way. For those that don't know, our problems start in our bone marrow. And blood cells are produced in our bone marrow. And here just the red spongy tissues where the different types of stem cells are that produce the different types of blood cell, and they are nursed and created and hang out in there until they're either called into action by the body or they're ready to jump out through one of the arteries and veins through the immune system that's shown there. I think it explains later on about as part of the symptoms of CLL that obviously this is an area where CLL cells themselves tend to accumulate, and that can cause some of the symptoms that we experience. I should have practiced, I didn't realise it was an interactive slide, so I've got to talk about other things very quickly. So, obviously, as I talked on there, the white blood cells, one of the white blood cells at CLL is found in the site. So this slide is meant to say practice. Blood stem cell, we touched on that, it makes white blood cells, platelets. This comes from a blood stem cell, which makes two different, basically splits into two when it's deciding what cell it's going to become. And we make millions, is it, Brian? Billions.
Tens of millions.
Tens of millions of no matter whether we're healthy or unhealthy. And effectively, the blood stem cell will divide into two, a myeloid stem cell, which will create some of your white blood cells and your red blood cells and your platelets. The neutrophils people will be familiar with, perhaps as cells that help fight infection, and eosinophils and basophils, I believe, are more about dealing with invasive organ. Part of the defense system. What do they deal with, right?
So yeah, the basophils are one of the least. I wouldn't spend a lot of time worrying about the basophils, but there's two kind of pathways here. One set is these myeloid. Myeloid means that it comes from the bone marrow, and they tend to have granules. And then how those granules stain tells you, the way the pathologist looks at them under the microscope. This is old school light microscopy where they'd look. And if they were neutral, they didn't stain. And if they stained with one color, they'd be basophilic, eosinophilic. All of these cells have different activities. Basophils are involved in allergies and that kind of stuff, and so are eosinophils. But the main one to worry about on that side are the neutrophils, which help you fight off bacterial infections.
Thanks, Brian. Stumbled there. Well, platelets, many in the room will understand. Platelets help with your blood clotting, so if you cut yourself or if you have a bruise, they're there to actually form a barrier. And your red blood cells, as we all know, carry oxygen around the body. And again, with CLL, both platelets and your red blood cells can be impacted. But that's not direct. That's an indirect effect of them collecting and crowding the bone marrow. Or alternatively, it'll be touched on later, that there are autoimmune conditions that can come along with CLL that might cause your body to take them out of the system. But the right-hand side of it is what we should be looking at. The lymphoid stem cell creates lymphoblasts that then decide if they're going to become B lymphocytes, T lymphocytes, or natural killer cells. And looking at this is the culprit. This is our companion. We didn't ask for this companion, but this companion's with us now. So, this companion is part of it. It's the B lymphocyte that's affected. Lymphocytes. So lymphocytes are produced, as we said earlier, part of the defense mechanism to help fight infection, to help produce antibodies so that the defenders can recognize and deal with your infections. And they are produced in the bone and circulate around a lymphatic system. And for those who didn't know, we have a red blood cell, we have a blood system that carries blood to and from the heart and oxygen around the body, but we also have a lymphatic system that deals with carrying lymph products around the body. And the thing about our sneaky little B cells is they live everywhere. They live in both the blood system and they live in the lymph system, and they can travel around in between the two, in between cells. So they are everywhere. But what's of interest from our point of view, as we know, we get the pesky lymph nodes and lumps and bumps where they tend to be found. You might have symptoms, for example, when we touch later, where they'll accumulate in the spleen. The liver might be enlarged. I'm not going to use these big words like splenomegaly or hepatomegaly. Yeah, I'm moving forward very quickly. Sorry, I heard you, Michael. Out of there. Quick diagram of how things happen. Basically, you have normal B cells. They will be caused under stimulation to reproduce by something in your body, which might be some invasive pathogen infection. What would normally happen is you get polyclonal expansion. Polyclonal means there'd be lots of different types of clones created and memorized by your body to fight infections. For some reason, we get a singular clonal expansion, which creates the CLL cell, which means that particular clone, a monoclone, mono meaning one, as in a monocycle, then reproduces. Initially, just a small group are created. Now, that could be a stable group, and then that creates another condition called MBL, which we don't need to talk about, but MBL really may never become CLL. It's a stable population. But have I been unplugged? Nick, you're talking too fast, or you're not? The unstable MBLs, I think 1% per year might become CLL. And CLL is defined when there are so many in the blood. I think it's above 5 parts per
About 5,000 per microliter of blood, yeah.
Thank you, Brian. Right, I'm getting out of here so I can hand over to my colleagues. CLL is identified under the microscope, where you can see these large round cells are lymphocytes that tend to be the CLL cells, where the nucleus covers the whole cell. And then we have these smudge cells, which for some reason in CLL they damage quite easily and are seen as these blurs, and that's one of the ways that they're found on the microscope. I'm going to pass this over to Michael, who's going to carry on about CLL and its...
Okay, just to explain to you, the reason we wanted to do this is that it's very hard to talk about CLL without it getting very, very technical. And what we were trying to do is when the doctor comes later on to speak, it's going to get very scientific, and I'm even lost when the doctor speaks. So we did this presentation in Prague at an international conference to other patient advocates, and we found that the patient advocates that had come, that had some understanding of CLL, but when they actually sat through that session, by the end of it they had much more understanding of exactly what's going on. But you can kind of see when Nick is trying to explain, I actually am a little bit lost on some of the slides, so don't worry, there's no test at the end of this, okay? So look, it's really, CLL had hit our family when Jan was diagnosed in 2011. I'm going to speak quickly because this is only a 20-minute session, and I do want Brian to speak as well, which is important. But in 2011, we knew nothing about CLL. We found that we had to gather up this information. We had to reach out to international patients that were going to start in clinical trials, had a much more understanding of what was going on. And what we realized was that CLL, you have CLL, but you need to know what flavor of CLL you have. And that's why we have these information days, so that patients have an understanding, because when you're going back to your GPs or maybe oncologists and hematologists, they may not be up with what's happening in the CLL world internationally. So the only way we can do it is maybe get the patients educated. So it's a difficult task. None of us, so maybe some of you went to medical school, but I didn't go to medical school. But you can gather the information, you can know what's going on, and it will help with your decision making. Now, the worldwide incidence of CLL is, as it says there, 1 and 5.5 per 100,000. To relate that to Ireland is that 10% of blood cancers in Ireland 10% of all cancers in Ireland are blood cancers. Out of them 10%, 40% of them are CLL. So it's the most common, even though it's a rare disease, it's the most common blood cancer. I'm right, that's the correct way of saying it. So I'll just, have you the clicker, just to click on that? What do we do here? Okay. So we do not know what causes CLL. We find on the forums when we're talking to international patients, a lot of war veterans that served time in Vietnam that were exposed to Agent Orange get CLL, and they've had to be compensated. So it's recognized that Agent Orange there's no way to prevent CLL. So nothing you did in the past made you have CLL. You'll hear that later on today, so I won't really go into it. You do not catch CLL from somebody else. In some families, more than one blood relative has CLL, and we have seen that here in Ireland, and we've also seen it internationally. There's a patient advocate that I work with from France, and his father had CLL, and he has CLL. So if I just move on, it's the most common adult leukemia in the Western world. Average age of diagnosis is 72, but some may be found in their 20s. Jan was diagnosed age 39. It's more common in men than women. It's higher in Jews, I'm not going to, sorry, lower in African, and especially in Asian. We tend not to see people from Asia with CLL. We'll hear more about that later on. Don't really like that slide, because I don't like getting into survival statistics, because 82% of patients survive in 5 years. You're worried about, are you one of the 20% or so? What you have to remember about that slide, 2006 to 2012, is all in the past, and even some of the statistics have been taken before that. And there was a groundbreaking change in about 2011 when they developed new inhibitors to treat CLL patients. So don't get too worried about that slide. We're into new eras, and nobody can say how long you're going to live, but it's really all to do with knowing, you know about your CLL, you know what flavor is CLL, and pick the right treatment option for you, which you'll learn about later on. CLL, the lymphocytes, they grow in the bone marrow, they crowd out the bone marrow. To tell you, Jan's bone marrow before treatment had 96% cancer cells. Today, after 5 years on ibrutinib, it's at 0.01%. So that just gives you a crowd. If it crowds out, if your bone marrow is getting crowded out, all of the other cells in the bone marrow can't form to fight infection. So you're going to pick up infection, you're going to become anemic, and they're all the symptoms that may need treatment, you know. Just bear in mind as well that a third of CLL patients will never need treatment. The symptoms, I've gone through that already, I've shot ahead, but just, you can see some of the symptoms there. The B symptoms, loss of appetite, unexplained weight loss, night sweats. Don't ignore them, go to your doctor. It may or may not mean that you need treatment, but don't struggle on. I've met CLL patients that kind of live with the burden of CLL and they don't go to their doctor. They might have an appointment in 5-6 months and they're waiting. And I just say to them, go to your doctor. You know, there's no need to struggle. There are options. Most patients have no symptoms when diagnosed. Okay, I'm going to pass you over to Brian because this is where it gets a bit technical, but it's very, very important. Okay.
All right, can you hear me? First, thanks so much to CLL Ireland for inviting me to be here, and I'm excited to see this kind of turnout. And I want to say it is an iterative process. You're going to hear stuff, you're going to hear it again and again and again, and maybe the 7th or 8th time you'll get it. Don't worry if you don't get it all now. Yeah, one good thing about CLL is, Nick pointed out, is it's chronic. You have time, there's no rush, you can learn this stuff. People learn it. These guys didn't know anything when they were first diagnosed. This doctor here didn't know anything about CLL when I was first diagnosed and had to learn about it. So we're going to talk about, we all have chromosomes, and the chromosomes determine our nature. The CLL generally has damaged chromosomes. Your chromosomes in your cheek, in your kidney, in your bones are not damaged. Only these particular lymphocytes that we learned about, these B lymphocytes, some of those are damaged, and that's a clonal population. It's like the movie about the attack of the clones. They're all identical, and they all have these chromosome deletions or chromosome problems. It's very, very common. These are some of the common ones. The important one to point out here is the 17p deletion. And why that's important, so P stands for petite, or the short arm. So we remember chromosomes look like 2 pair of pants sort of sewn together in the middle. And the short arm of the 17th chromosome carries a gene that says, I'm a damaged cell, I need to repair myself, or I need to commit suicide because I shouldn't have kids, I'm damaged, I shouldn't reproduce. If you're missing that gene, you can have all the chemotherapy in the world, damage the cells terribly, and the cells just keep going on and reproducing and being more and more damaged. So it's very important to have this test done to check for these chromosomes. And the test for this is easy to remember. It's called FISH. You go fishing for this. It stands for fluorescent in situ hybridization, but just remember FISH. There's, on that chromosome that we talked about, there's a protein called TP53, and that's the one that we just talked about. You can have that mutated and not be missing the 17p, and that's another test your doctor can do, and that's done by next generation sequencing. And this is another important test to have done before you have any treatment. There's also another test that says, what kind of CLL do I have? It's very important. You heard about this heterogeneity, this variation. Some people have a normal life expectancy with CLL. Some people need treatment quickly. Looking at the IGVH mutation just tells us how mature that CLL cell is. And if the cells are immature, like teenager cells, they tend to be reckless and wild and maybe make some bad decisions. But if they tend to be more mature, they tend to do better. So in order to become more mature, a lymphocyte has to be taught how to recognize other proteins, like the streptococcus protein, for example. Okay, it wants to attack strep, or the flu, it wants to attack that. And in order to recognize the flu, it has to be mutated. To be mutated means that it's been changed to recognize it. So ironically, it's really weird, because you want to be mutated in your IGVH, which is what recognizes these foreign proteins. Unmutated is bad, because those are immature. And there's about a 50-50 split in CLL. So that's an important test for you to know, because it has prognostic and predictive significance. There's other markers too, and these that you'll be learning about. And these just sort of tell you about the tumor burden, the beta-2 microglobulin, and the clusters of differentiation are markers on the top of the cells that tell the pathologist, is this CLL or is it a different disease? I'm going to talk a little bit about management here. And one of the weird things is everybody's told, go out and get your pap smear because we want to catch the cervical cancer early. Get your mammos. Men, get your PSA. Everybody get their colonoscopies done to check for colon cancer. And then you see a doctor and he says, we did a blood test on you. You have CLL. I'll see you in 3 months. You say, are you really a doctor? I mean, you just diagnosed me with cancer and you're not doing anything. And the reason is that there's no evidence that early treatment helps. And you might be part of that significant minority of people who never, ever, ever need treatment and have a normal life expectancy. And no drugs are without their side effects. So that's why we call this watch and wait, or now they call it active observation. So the principles of the treatment we touched on is to do this prognostic and predictive testing to see what your best options are. New therapies are coming so quickly now, and often a clinical trial is your best option, and we're going to talk about that, and you want to share these decisions. So we talked about the clinical heterogeneity, the spread of the different people, the long survival. We talked about prognostic tests.
What does heterogeneity mean?
So heterogeneity means variability. Homogeneity means it's all the same, like homogeneous milk, So hetero means multiple. So heterogeneity means, and if I use a word that you don't, you stick up your hand, because sometimes I talk medical aids.
CLL patients are not the same.
Right. So what I like to say is, if you know one CLL patient, you know one CLL patient, because every case of CLL is different. It's not like treating a strep throat, okay? Every case is different. Every case needs different management. Everybody is different, and that's why knowing what your prognostic and predictive factors are, and also, do you have kidney disease, or you're diabetic, do you have hypertension, do you have heart problems, all of these things play into what the treatment should be. So there's tremendous variability or heterogeneity in how it's treated. Right now, there's no curative treatments, but there's a question mark in front of that, because there's some excitement that there may be some curative therapies that we'll talk about a little bit later. And again, this last line is just telling us about the role of watch and wait. And there's a space between diagnosis and treatment. It's rare to need treatment right at the beginning. So there's this term that we use in CLL called cognitive dissidence. You're told that you have a cancer, but you don't need treatment right away. So it's very confusing and upsetting, and you're just living with this. This is a very difficult time for patients. And I think with that, we'll move on.